cervical OPLL, and we will share very innovative talks and very scientific discussion we will have. The first talk will be given by Dr. Fengzeng Jian, risk factors of dural tear during anterior decompression of cervical OPLL. Yes, Dr. Jian.
Okay, thank you, Professor Zileli. Hello, dear colleagues and friends. Today, I'd like to talk about some specific complications of anterior surgery for cervical OPLL. That means dural tear and CS leak. It is estimated that the dural tear and CS leak is as high as 31% during anterior surgery. So this is why I chose this topic. So mainly, I am going to focus on the preoperative evaluation of dural ossification, and because this is largely the reason of CS leak and dural tear. Additionally, I'd like to talk about a floating technique and how to perform a floating technique in order to avoid the dural tear. According to a meta-analysis in 2016 of OPLL surgeries, the incidence of dural tear was estimated to be as high as 31%, as I said, for anterior approaches. And this is largely because of the dural ossification, which is estimated to affect between 15% to 29%. And I think this incidence is inconsistent with the instance of CS leak during surgery. It is because of the dura itself ossified. That means the dural tear is doomed to happen if our surgical goal is to remove the OPLL completely. So if we could find out the dural ossification preoperatively, it will be very helpful for the surgical planning, for the estimation of risk, intraoperative, and including also intra and postoperative management of the CS leak. Oh, sorry. Oh, there's some problem for PPT. Sorry. Okay. So for this reason, we performed a retrospective study 2 years ago. The study included 90 patients, which we used anterior approaches, including 12 patients which had dural tear intraoperatively, and 79 patients no dural tear intraoperatively. We compared the other variables, including the age, BMI, and the comorbidities, such as diabetes, tobacco use. It seems, even though heterogeneous of the two groups, but these variables is equal. So for the two groups of patients, we compared the following parameters to evaluate the risk of dural tear. For example, the OPLL level, one or two levels, or more than 3 levels. A type of OPLL, that means continuous segmental, etc. Additionally, another very important parameter is the WL sign in CT scan, specifically C sign And key line also, we studied also intramedullary signal change. Of course, we compared also occupational ratio and basal ratio of the OPLL. Now, let's see in detail these parameters. Now, as we all know, the OPLL is classified as segmental, continuous, combined, mixed, or a localized type. So this is the measurement we performed in this study. The occupying ratio, that means the thickness of OPLL to the AP diameter of the cervical canal. We compared also the K line. The K line is negative or positive. Most importantly, in this study, we compared the shape of OPLL in axial view of CT scan. Now we can see in a study published several years ago, the authors compared the shape of OPLL, and they divided the OPLL into 3 types: the crescent type, the straight type, and wide-based type. Yeah. All of these 3 types associated with double layer sign in CT scan, you can see here. And the authors found that the incidence of CSF leak in type A was only 4%. And in this type, that means a wide-based OPL, this group of patients had 100% of CSF leak. We compared also the basal ratio, that the width of the OPL to the diameter of cervical canal. Very interestingly, in about 20 years ago, Dr. Epstein suggested a C sign of OPLL is associated with a high risk of dural and CSF leak. That means a lateral localized OPLL with a C sign, with a hook-like C sign. So here's the result. We use a multivariant analysis, and the result showed the C sign has a statistical significance, and also the basal ratio has a statistically significance. Unfortunately, we did not find the double layer sign has any significance. It is because we think it is because mainly the statistical method we used. But if we see the absolute value, it seems in the dural tier group of patients, 10 of 12 patients had the dural tier, and in the other group, the control group, there are 27 patients. That means about 1/3 of patients had double layer sign. I think this value is consistent with the study that the double layer sign has a sensitivity of 55% and a specificity of 97%. And I think this study is consistent with the previous one. So here's an example: a patient of 41-year-old male, and we can see the patient has a double layer OPLL. And intraoperatively, we found the dural ossification. You can see here. And we left it intact. That means we use a floating technique. This is another another patient of 39-year-old male, presented with a numbness and pain of the upper extremities. And for this patient, there's a dural ossification, and we removed the dural and the ossified ossification. Unfortunately, we leave the arachnoid membrane intact. This may be a C sign, but not very typical. You think not very typical C sign. Actually, I think in the report of Epstein, he reported only 2 cases of patients. But we literally, after in our daily work, we found that maybe the shape of OPLL in a mushroom shape, maybe it's very similar to that C sign. We can see here is a mushroom shape. Maybe it's associated high risk of dural ossification and dural tear. Here's the example, very interesting case. The patient was diagnosed cervical spine stenosis in 2012. So the patient underwent surgery of a laminoplasty in the local hospital, and post-operative CT and the post-operative MRI showed a very good clinical good image. But in 2018, the patient's symptoms worsened, and this is the MRI. And from here we can see that the restenosis of the spinal canal. Now let's see the CT scan in 2018 and compare it to that one of 2012. There's obviously a OPLL. The OPLL is growing or a new one. We are not sure. We are not sure is a new one or growing from the original one. If we can diagnose, if we could diagnose in 20s previously the OPLL, I'm not sure. Anyway, for this patient, from the axial view, we can see on CT a mushroom shape of OPLL. So during surgery, we found that the OPLL was completely adherent to the dura. Actually, its dura itself ossified, and we performed complete decompression and removed all the dura and the ossified ligament. Oh. This is an axial view of the MRI. Anyway, we got complete decompression of the spinal cord. This is another case of 15-year-old male with a negative K line. Can you see? With negative K line. And post-operatively, we found, can you see here? We found a small leakage of the dura. Even though intraoperative, we did not find, we did not notice any dura tear. But unfortunately, after surgery, we found the liquid anterior to the cervical spine, and 3 months later, the CF leak disappeared. So, in summary of the risks, the patients with a tubular sign are more likely to have a dural defect or dural tear intraoperatively, especially those with wide-base ratio. And there's a moderate correlation between modified single layer with sign and dural ossification. So the next thing we should do is how to avoid dural tear during surgery. So in a study compared the anterior surgery, mainly the fluting technique and the posterior laminoplasty. And the study showed that all patients worsened during follow-up, dropped in the group of laminoplasty. That means if we use fluting technique, which is widely accepted as the OPLL, if we use the fluting technique adequately, the clinical outcome will be excellent. In another study, the authors compared intraoperative CT. They found that they found patients with massive OPLL in non-CT group had incomplete fluting of the OPLL in about 16% of patients. So the authors addressed the usefulness of intraoperative CT. And this is also what we experienced. Of course, during surgery, during OPLL surgery, the key points for sufficient decompression is the anterior procedure for massive OPLL, adequate orientation, adequate width of decompression, and adequate thinning of the OPLL. So this is another good indication for intraoperative CT. So here's an example. If we find the image like this after surgery, it'll be very awkward for us to manage. But if we found intraoperatively, for example, this one intraoperatively using intraoperative CT, we can continue to remove the OPLL continuously and safely. So how to perform fluting technique? This is our experience we used. The wide exposure is necessary. And the drilling of the OPLL should be performed under microscope. And instead using sharp dissector to separate the dura and OPLL, we suggest to use the blunt-headed probe. And I will show you later in a video. Intraoperative CT is very helpful, especially in patients with complex or very big OPLL. Here's an example of a 56-year-old female suffered from numbness and weakness of her right arm. We can see here from the MRI there were two levels of spinal cord compression, and in CT scan we can see OPLL mainly located in the C5 C6 level. Unfortunately, we lost the axial view of CT scan, but from MRI, it seems the OPLL was a C-shaped. So that means there's a high risk of dural ossification. But for this, during surgery we use a fluting blunt probing and fluting technique. To dissect, you use the probe. If there's enough space, we remove the OPLL using kerosene. Anyway, during surgery, we try to reduce the size of OPLL as small as possible. Usually, we leave.
哒哒哒哒哒哒哒哒哒哒哒哒哒。
哎，你这田福明的，你把这个关了，你的音频好吗？ Usually we leave the one side of OPL connected to the vertebral body until the end of drilling. Finally, can you see using the using the blunt-headed probe to release all the OPL. This is a post-operative CT scan. We can see only a very thin layer of the OPL remained, and the post-operative MRI demonstrated adequate decompression of the spinal cord. Besides the fluid technique we discussed in recent years, there are two reports read 2 years ago about a new technique, the anterior shift of the vertebral body together with OPL. So I think Dr. Chen will talk this technique. This technique was reported almost simultaneously by a Chinese group and a Korean group. Of course, as spinal neurosurgeons, we are all very familiar to the management of CS leak. A stepwise management is very helpful during, for example, during surgery package of the during surgery package and with spinal drainage of CSF is a daily is a routine management of CSF leak post-operatively. Fortunately, even patients with Dural and CSF leak, the clinical outcome is almost same to that of without Dural T. Only the length of hospital stay will increase. So, in summary of my topic, the risk factors of dural ossification and CSF leak include wide base ratio and double layer of OPLL in CT scan, and a C-shape or mushroom shape of OPLL with a negative K line. I think these are all the risk factors we can identify preoperatively. And during surgery, the blunt probing and the fluid technique could help avoid the dural T and CSF leak. Finally, we also suggest to use intraoperative CT overarm to help orientation and adequate decompression of the OPLL. Thank you.
Thank you, Dr. Jian. It was really very great lecture. We have troubles if a dural tear happens, because the CSF leakage from anterior in the cervical spine is quite difficult to manage. My question is, what do you do in if there is a CSF leakage from ventral? What is your management protocol?
Actually, here's
do you apply lumbar drainage?
Yeah.
Do you place T cell on the dural edge? What?
Yeah, here's our protocol. Can you see?
Yeah.
Actually, a step step-by-step management of the CSF leak. Actually, for majority patients, we can manage to heal the leak by spinal drainage, usually 5 to 7 days.
5 to 7 days.
Yes.
Okay.
We have never had a case.
Do you use a Dural patch or something?
Yes, we use Dural patch intraoperatively, but we just lay the patch on the surface of the spinal cord.
Okay. Okay, there is one more question. Are you recommending neuromonitoring during surgery in such surgeries? Do you perform monitoring, intraoperative monitoring?
Yes, I think it's useful. It depends on the availability of the monitoring. Several years ago, we had not used monitoring, but recently, yes, as a routine technique to monitoring.
Okay. Do you sometimes use fat to place on the dural tear site? Fat.
We actually theoretically, yes, in some cases maybe it's helpful, but we have never used it.
Okay. Dr. Nikolai, or do you have any other questions?
Yes, it was very good presentation, and I really enjoyed that. And it was a comprehensive review of what can we do and what problems can we have. Definitely helpful to consider the CT. I will just make a comment. I don't have questions. Definitely helpful to consider CT scan before you address this pathology, because that will prepare you for any possible troubles. Thank you. Thank you so much for that.
Thank you.
Mehmet, can I just comment?
Yeah, please. Welcome.
Sure. Thank you. Finally, I got in. I apologize. There was some delay with Zoom. There are lots of people waiting to join in, because I'm getting messages from our residents that are waiting in the lounge that they need to be accepted. So we need to do that. Regarding CSF leak, yes, with CSF leak, many times you can get away with murder. Actually, anterior CSF leaks, if dealt appropriately, really do not give any trouble. I generally use Tacosil, which is basically a sealant on one side and a Dural substitute on the other. And I put it in every patient, and it just sticks to wherever it is. You don't have to put any stitches. And it's worked very well for me. I've never, ever touched wood, had a problem with a CSF leak, and hope that I won't. One of my colleagues, he doesn't use it and uses lumbar drains, but he keeps it for 2 days, and he has not had any problems. So I think you can do it many other ways, and they're all fine.
Good.
Oh, thank you.
Tacosil
One
is
more question.
very good. Yeah, I also have good experience with that.
Yeah.
Sorry,
yeah.
Mehmet.
Yeah, Oscar. We listen.
Oscar is on a boat.
Oscar, unmute yourself.
Unmute.
Oh yeah. Sorry. So what I do usually is to use some Dural patch, and I think the physiology is really on our side, because the pressure on the CSF column is not so raised as in the lumbar spine, not so high. That's why most of these CSF leakage from anterior surgery, they do well.
Okay.
Yeah, another thing. Hi, Oscar. Good to see you.
Hi.
Another thing that I was taught by a couple of Japanese friends some time ago was that if it's a very, very tight OPLL, what you could do is you could put a lumbar drain in advance and relax the dura. And once you do that, then you're not going to run into trouble again, and it's easier to remove that plaque in front, and the chances of causing a problem is minimal. I don't use monitoring. I don't have but I don't use monitoring. Even if I'm in place where I have it, I just make sure that the blood pressure is up and the perfusion pressure is appropriate. And up till now, we have not ran into any trouble, and that's what I teach all my residents as well.
Is that published somewhere about the lumbar drain? Because I don't know, I don't have experience with that, but my concern will be that if you reduce the intradural pressure, that might actually increase the chance of injuring the spinal cord. How you would comment on that?
I had a discussion with our friend, and he has written a paper on it, and I can share with the group. I'm sure I can find it somewhere on the laptop. It's a few years ago. I met him in Dubai spine meeting, his perception was in every tight case he's doing that, and he hasn't had any trouble. And actually, they were measuring intra spinal pressure as well as keeping an eye on maps. So they were seeing exactly what kind of pressure, spinal perfusion pressure is going on, and at the same time of doing this. And they published that spinal perfusion pressure somewhere, which I have somewhere with me. I'm sure I can share with you later on.
Thank you.
Yeah, I have the same idea. I don't think there is any problem with this spinal perfusion in case of CSF drainage.